Hi, thank you so much for having me. I really appreciate the opportunity to be here, so thank you to the organizing committee. I am Susan Corbridge. I'm the Associate Dean for Practice in the College of Nursing at the University of Illinois, and I maintain a clinical practice with the Division of Pulmonary Medicine. And I want to today, I was asked to talk about workflow, so I really want to talk about interprofessional practice and interprofessional teams. I'm a huge advocate for this, and I believe that it really can change everything and help us with what we're trying to achieve with workload, quality, as well as burnout. So in a nutshell today, what I want to do is review the evidence briefly of interprofessional teams, again, on workload, burnout, and then quality of care. And depending on time, I'll provide 2 examples from our Institution of Interprofessional Team Modeling, and then recommend strategies for implementing interprofessional team-based models. And I was happy to hear this morning that Dr. Smith and Cipriano were talking about the new team-based paper that's coming out, so that's exciting to see. So we do know that interprofessional teams decrease workload, and that's really what we're trying to do. Of course, workload contributes to burnout, which contributes to poor quality of care. So interprofessional teams do decrease workload. We also know that interprofessional practice frees up time for other medical services, and I see this in our pulmonary clinic all the time. Our pharmacists are so incredibly fabulous, and they we could not do what we all do in our team without them, because they're just so great, as well as the pulmonologists, and everybody brings different skill set. And our patients, as we all know, are so much more complicated than they used to be. They come with a variety of just a myriad of issues, as well as there are so many other things that make workload so incredibly difficult. So it's very important that we all come together and use our combined skill set. Also, when you have an interprofessional team, you have a shared knowledge of an investment in the patient. And our patients, again, in the inner city of Chicago, they're very sick. They frequently come back often, and they have unscheduled visits. So it's great that we all know the patient. We're invested in the patient. If they need an unscheduled visit, we know them. Somebody's able to step in, and so we come together collectively as a team, and that's been really helpful with that. So, of course, as you decrease workload, you can also decrease burnout. However, independent of that, interprofessional practice has also been shown to decrease burnout, which is what we're trying to do. Relationships, in particular, are very important to job satisfaction, which of course decreases burnout. And when you work as a team, in a high-functioning team, you really, develop great collegial relationships, and you can learn from each other. I've been a nurse practitioner for over 20 years, and I learn something new every day. And the pulmonologist, one of the pulmonologists I work with, has been in pulmonary critical care for 30 years, and he said to me the other day, "You teach me something new every day." And that's just how our group works. And I think when we all come together with those different skill sets, whether it's the MA bringing something in, or the nurse bringing something in, or the pharmacist or the social worker, we're all learning something new. So that's very important. The other thing I don't have up here, but about burnout, is uncertainty. I think for anybody who takes care of patients, we know that uncertainty happens often. And how many nights do we lose sleep over a decision we've made? And uncertainty can create stress. So sharing the stress with each other, and that's really a big, important piece. And it's nice to be able to call up your colleague who's also just as invested in the patient and say, I'm really stressed about this. And having that, being able to bounce that off each other is very, very important. In addition, independently, interprofessional teams can improve patient quality, and that's really, of course, why we're all here. We know that the data support that interprofessional teams can lead to earlier diagnoses in patients, and again, we haven't measured this in our group, but I do feel that is the truth. 2 heads are better than one. So they say, and collectively, all of us together come together, and I think that's the importance of teams. Again, increased provider knowledge. As we say, everybody's busy, but somebody's reading a new paper or bringing something in that you might not have time individually to do. So it's so important for that team piece. Also, your patients are very satisfied, and they're willing to go, and they trust you. They trust you as the team. And so when you add new members to your team, they're more willing to go see that individual. Or if we bring students into the team, they know us as the team. So they say, okay, I'm willing to sit with a pharmacy student, and I really love this. So I think that's very important. And then if you look at the data for interprofessional teams and ICU outcomes, that's quite striking as well. And I think also, there's data that support that when everybody has a seat at the table, and they're not just there to provide a particular skill, but they actually have a seat at the table and an investment in the patient, no matter who they are, they have more buy-in, and so there's more accountable practice. And so I think that's really important in teams, and I see that as well. So I think that's so important that like even with our MAs or the people, who are checking in our patients at the front desk, that they, we all know we're there for the same reason, and I think that's an important piece for teams as well. So two models that I'd like to share with you. One is in our pulmonary practice, and that is a picture of our hospital. Again, we sit on the west side of Chicago. That picture is important because you see the bridge that's stretched across there. This has to do with regulatory issues. Our clinic sits in, it's considered a hospital outpatient clinic, so we're able to do shared billing when the pulmonologist and I both, or the billers, both have to see the patients at the same time. And so that was one of our biggest issues, was to try to figure out when you have multiple billers, how are we going to do this, and how are we going to do it right, and how's the documentation going to work, and how does that support? And that really was kind of a hurdle that we had to get over. But because we are considered an outpatient hospital clinic, we're able to do shared billing, so that wouldn't necessarily be the case in other places. But I find that with other models as well, depending on where you're practicing, of course, you have to jump over the regulatory hoops and be sure that you're practicing according to standard of care. In addition, so this, everybody sees with a model that this isn't anything unique, except for the fact that the way that we have ours set up is that, again, we practice in the inner city. We have a patient population that has a high level of non-adherence. They use the ER frequently. We also have a lot of illicit substance abuse. That's why we're seeing them for pulmonary manifestations from illicit substance abuse. And that's been one of the biggest changes that I've seen in my practice in 20 years, is that we're just not armed to take care of the amount of illicit substance abuse that comes in. So our community partners have become important with that. We also have fellows in our clinic, which when our fellows then rotate through, they've seen all the patients with the pulmonologist, and when our fellows rotate through, then I usually will inherit those patients, and they'll continue in the team, so they're known to the pulmonologist as well when we all have to pull in. In addition, the pharmacist and I usually flip rooms, so that's always very helpful. And again, our biggest drugs, of course, or medications that we use for our patients in pulmonary are inhalers. And for those of you who work with pulmonary medicine or any type of inhaled medications, there's just been an influx of new inhaled medications. But our biggest problem is that our patients are not able to get a lot of the medications that we write for, that we want to write for. So without our pharmacist, we are not really able to practice the way that we need to with all the hurdles. Most of our patients are on Medicare managed care plans, and so their insurance will change every few months of what they're able to get. And our patient population they're not strong advocates of themselves, that when they go to the pharmacy to pick up their medication and the pharmacist says, well, this isn't covered, they're not going to just keep trying to get it. So then they'll end up back in the emergency room. So it's very important for us in the clinic setting that our pharmacist is checking, can they get this, can they do that? And it's just such a great resource, and that's very helpful. We also have a lot of students from all different walks of life, and we've heard this today, that I think it's very important that we're role modeling really good interprofessional team-based care to the next generation. I think that's really an important piece. And again, recognizing that there are many other people that need to sit in the team, including the community partners, social workers, and administration. We can't forget that administration is very important to pull into the team as well. So the team continues to grow, but that's very important. And then just a second model that I wanted to cover in my role as Associate Dean, I oversee our FQHC. It's our nurse-managed clinic on the west side of Chicago. Our university has several FQHCs, and one is a nurse-managed clinic that it is run by the College of Nursing. And so I oversee this clinic. And in this patient population, it's the same type of patient population, west side of Chicago, inner city, very underserved population. And our model there, what we have needed to see, it's different than in our pulmonary practice, but the issues that I'm finding putting together a team-based model of care are the same. It's just that, we're tied by the regulatory issues of the FQHC in this instance. So I think that's an important thing to keep in mind. We recently received HRSA funding to switch to a collaborative care model. As you know, and as you can imagine, on the west side of Chicago, many of our patients need mental health services. And with the decrease and shortage of mental health care providers, we're now moving to this collaborative care model. And again, we've received HRSA funding to do this. So this is our new service delivery model, and some of the interprofessional team-based pieces, again, that I've learned from my own pulmonary practice and from my years with other interprofessional pieces, that it's the same type of issues, just a little bit different, but some of those regulatory hurdles, again, are surrounding the FQHC and those pieces. In addition, though, that buy-in is very important for the MAs, for the team, and so it's important to have everybody recognize what they're doing. The other thing just about modeling as well, one of my colleagues from another large institution in Chicago, he's head of pulmonary and critical care, called me the other day and he said, our model in the ICU isn't really working. And so he said, can I run this by you? So we're talking back and forth, and again, I thought these models and putting together team-based models are important. So I just want to, just because I'm getting the stop sign, I just want to say one thing that I put some strategies up there, and I know this will be in the team-based paper, but one of the things that I think is really important is that we advocate for top-of-license practice for all providers. I think it's very important that everybody's able to practice their full scope of practice and without restrictions, which is definitely key. There are many, many sick patients, and by restricting practice for individuals, it definitely increases workload and for the providers, as well as it really hurts the patients. So I think that's a big piece for team-based care. So thank you.
Thank you.